Just think for a second about everything you do with your hands. Typing, lifting, weaving, you name it. And all of that is powered by your wrist, which is this incredibly complex piece of biological machinery. But what happens when that machinery breaks down? Well, today we're going deep on the unstable wrist, a condition that can turn the simplest movements into a real source of pain and weakness. So, let's dive in. Okay, so for your wrist to handle everything from a heavy push-up to just picking up a cup of coffee, 3 things have to work in perfect harmony. First, you've got the muscles that cross the joint, giving it that dynamic support. Second, the surfaces of all those little carpal bones, they have to glide smoothly against each other. And third, and this is the big one, you need a dense web of ligaments holding everything together like a tightly woven net. It's a really finely tuned system, and believe me, when one part fails, the whole structure is at risk. So what happens when this perfectly engineered machine does break down? Well, that's what this is all about. We're getting into the unstable wrist. So what exactly is carpal instability? Well, I want you to imagine the bones in your wrist like a really finely balanced stack of blocks. Instability is what happens when the glue, the ligaments that hold those blocks together gets damaged. All of a sudden, the bones start to shift and wobble under just normal everyday stress, and the entire structure just becomes unreliable. Now, this instability usually shows up in one of 2 main ways, and they're named for the direction that one particular bone, the lunate, starts to tilt. In DISI, which stands for dorsal intercalated segment instability, the lunate tilts backward. And this is by far the most common pattern we see. In VISI, the lunate tilts forward. Now, because DISI is the one we see most often, that's what we're going to be focusing on for the rest of this explanation. And here we go. This x-ray shows you exactly what that backward tilt looks like. Normally, these carpal bones should form a nice, smooth, continuous arc. But look right here. You can see the lunate bone. That's the half-moon-shaped one in the middle. It's tilted back, and it creates this really clear disruption. This is the classic telltale sign that the ligaments that are supposed to be holding it in place have failed. So, which specific part of this whole support system is the culprit? To answer that, we need to look a little closer at the anatomy and really focus on the single most important ligament in this whole story. So let me introduce you to the Scapholunate interosseous ligament, or SLIL for short. This guy is pretty much the star of our show, and unfortunately it's also the most commonly injured ligament in the entire wrist. It forms this critical bridge between 2 key bones, the scaphoid and the lunate. Now, it's a complex structure, but the part that really matters the most is the dorsal part. It's the thickest, it's the strongest portion, and it's the primary thing that prevents the lunate from tilting backward into that DSI pattern we just saw. For decades, everyone thought the story pretty much ended with the SLIL. But then a landmark paper from Dr. Christoph Mathulin and Dr. Abhijit Wahagankar completely changed the game. They discovered a direct connection between the SLI ligament and the overlying joint capsule, a structure they named the Dorsal Capsulo-Ligamentous Scapholunate Septum, or DCSS. And I'm telling you, this was a huge development in understanding wrist stability. And this dissection right here shows that very structure, the DCSS. So why is this so important? Well, it acts as a critical secondary stabilizer. Think of it like a backup support system for the main SL ligament. And its discovery really changed how surgeons approach treatment, because it suggested that, hey, maybe just repairing the ligament itself isn't enough. You might also have to address this crucial capsular connection. All right, so with all this complex anatomy in mind, how do clinicians actually figure out what's wrong? The diagnostic process is kind of like a detective story, where you gather clues from the patient's experience, a physical exam, and, of course, some advanced imaging. It all follows a pretty logical path. First, you just listen to the patient's story. They'll complain of pain on the back of the wrist and weakness when they try to do things. Then comes the hands-on physical exam. After that, you move to imaging, usually starting with simple x-rays. And finally, for the definitive look, surgeons turn to arthroscopy, which is really considered the gold standard. Now, this is one of the most important physical exam maneuvers. It's called the Watson scaphoid shift test. What happens is the examiner applies pressure over the scaphoid bone while moving the wrist around. In an unstable wrist, this actually forces the scaphoid to shift out of place over the back of the radius bone. And then, when the pressure is released, it pops back in, often with a painful and very noticeable clunk. It's a simple test, but it can strongly suggest an underlying ligament tear. Then, on an X-ray, this is the classic sign we look for. See that big gap between the scaphoid and the lunate? That's called the Terry Thomas sign, and it's famously named after the British comedian who was known for the gap in his front teeth. A gap of 3 millimeters or more is a pretty clear indicator that the SL ligament has been completely torn. But really, for a definitive look, surgeons turn to arthroscopy. By putting a tiny camera right into the joint, they can see the damage directly. There's no guesswork here. You're looking right at the frayed, torn edges of the scapholunate ligament. This confirms the diagnosis and lets the surgeon plan the absolute best course of action. So the diagnosis is confirmed. What's next? This brings us to the treatment phase, and there's a particularly elegant framework that surgeons use to turn what is a very complex diagnosis into a clear, stage-based plan. The beauty of this framework, which was developed by Dr. Mark Garcia-Elias, is just how simple it is. It boils down this whole complex problem into 6 key yes or no questions. By just going down the list, a surgeon can assess the state of the ligaments, the alignment of the bones, and the condition of the joint cartilage. It's brilliant. So answering these 6 questions automatically classifies the injury into one of 7 distinct stages. But this isn't just some academic exercise. Each stage corresponds to a different rung on a treatment ladder, guiding the surgeon from the simplest repairs for early injuries all the way to really complex salvage procedures for advanced cases. It's a logical path through a very, very complex problem. All right, let's climb that treatment ladder. We're going to start with the options for the earlier stages when the joint is still salvageable, and then move toward the really tough choices that have to be made when the damage has become irreversible. For those earlier stages, when the cartilage is still healthy and the alignment can be fixed, the goal is reconstruction. This might mean directly repairing the torn ligament. Or, thanks to that discovery of the DCSS, surgeons can do a minimally invasive procedure, like an arthroscopic dorsal Capsulo-Ligamentous repair to tighten up that key secondary stabilizer. Other techniques, called Tenodesis, actually use a strip of a nearby tendon to create a new reinforcing ligament. But what happens if the instability goes untreated for too long? Well, that constant abnormal motion starts to wear away the cartilage. This leads to arthritis, a condition that has a very specific name in this context, SLAC risk, which stands for Scapholunate Advanced Collapse. And at this point, all those nice reconstructive options are pretty much off the table. When a risk gets to this stage, the focus shifts from repair to salvage. The 2 main options are a proximal row carpectomy, or PRC, which removes the entire first row of carpal bones. Yeah, the whole row. The other is a 4-corner fusion, which takes out only the arthritic scaphoid and then fuses the remaining central bones together. As you can see, it's a clear trade-off. The PRC gives you a little more motion, while the fusion gives you a bit more grip strength. These are really difficult decisions for both the surgeon and the patient. But here's the twist. The story isn't always a straight line from a torn ligament to an arthritic wrist. As this quote from an international committee of experts points out, not every torn ligament leads to a collapsed, painful wrist. Some people actually tolerate these injuries surprisingly well, and honestly, we're still trying to figure out why. The full story of this condition is definitely still being written. And that leads us to our final question. We spent this time talking about the wrist as a mechanical system, right? A system of bones and ligaments, but it's also a biological one. It has nerves that give it something called proprioception. That's the joint's own innate sense of its position in space. So as we learn more about this biology, will the future of treatment move beyond just mechanically tightening things down? Could we actually develop biological solutions that restore the joint's own intelligence, not just its structure? That's the big question that's driving the next generation of research into the unstable wrist. Thanks so much for joining us for this explainer.